The next hour, we're going to be talking about the next step in understanding Medicare's function and importance in your lives, if not now, ultimately, eventually. The first part looked at the initial process, understanding generally what Medicare was as a system, as a program, and how you enter that system. We're going to dwell more in depth today about the various kinds of private insurance products that are under the Medicare system. Those products that enhance the basic platform of Medicare, Part A and Part B. These private insurance products are Medigaps, Advantage plans, and drug coverage. We're going to look at how these particular products work, how they work with the Medicare Part A and Part B platform, and more importantly than I think anything, how you can make effective choices for accessing the coverage and the utilization of those services. So let's start with just recapping the basic tenets of Medicare. For those of you who attended, it'll be a little redundant for those of you if this is your first pickup. This may give you a little bit of an idea as a basis for what we're going to be talking about next. So Medicare, as it was conceived and as it still exists, that represents the government, is in two parts. The Part A portion of Medicare, which represents government's coverage for inpatient services in hospital, skilled nursing or rehab facilities, home care, and certain other kinds of services that tend to be categorically looked at as inpatient. Part B is the other kinds of services that are typically defined as an outpatient status for the individuals receiving those services. And together, this was the vision of what Medicare was going back to the 1960s. This is still what it represents as its initial basis. This gives you some specific ideas of what Part A and Part B covers, but there are also certain things that Medicare Part A and Part B will not cover, and in general, the Part A and Part B portion of Medicare coverage is not going to cover the entire cost of these services. So individuals entering Medicare expect a premium, not for Part A. Most individuals, more than 90% of the individuals in Medicare, have a zero cost to be enrolled in the A portion of Medicare. And that's because you've earned it over your working lifetime. Individuals that are working and are paying into the Medicare Part A system each year by having a tax automatically withdrawn from their paycheck. Not a very large percentage, but it is the amount that represents your contribution to the Part A system of Medicare. If you have contributed over 40 quarters, think of each year as divided into 4 quarters, 10 years, 40 quarters. So if you worked and paid into the system for at least 10 years during your lifetime, or if you have a spouse that has done that, then you have an expectation that your Part A is zero. If you have worked less or paid in less to the system, then the Part A will have a premium cost, and that could be the largest portion of what you have to pay just to be in the Medicare basic system. Now, Part B is always assumed to have a premium, and we talked last time about how that's determined and measured. And for this purpose, simply know that there's going to be some amount that is going to be assigned to your enrollment in Part B. It's a monthly amount per person, and it's typically either going to be automatically taken from your Social Security benefit check if you're receiving Social Security benefits at that time, or if not, then you're going to have to arrange with the Medicare system to make that monthly payment. It's going to be at least $148.50 per month currently per person. That will likely change from year to year. It will likely go up a bit every year. And if your income is higher than the base amount, then you will be paying not only that $148.50, but also an income-related Medicare adjustment amount, an IRMA. And that amount could, at some point, if your income is large enough, be in excess of the $148.50. You may be paying more of an IRMA than you are of the base amount, but at least all individuals in Medicare will be expected, they will be paying at least that almost $150. And I tell you that because when we start looking at costs of other products, anticipate that regardless of what else you're going to pay, you're going to pay at least the Medicare Part B premium, whatever that amount is. So I'm going to use that as a constant. And when referring to the cost for Medicare, anticipate that that is not being mentioned. It's already assumed that you're going to be absorbing that as well. So as I said before, Medicare from its beginning was assumed that individuals enrolled in Medicare would be mandated to generate a cost sharing requirement. Medicare was never presumed to pay the entire cost of services, but back in the 1960s, that cost sharing was not presumed to be so onerous that individuals could not afford it out of their own pocket. And was typically based mostly on percentages. So if you utilized an outpatient service under Medicare, Medicare would pay 80% of the cost. You would be imposed to pay the other 20%. Now, back in the 1960s, 20% of outpatient services was presumed to be not that expensive and thus absorbable by the individual. 20% of what the cost of outpatient services or some percentage of inpatient services or whatever the excess cost that the individual is required to pick up particularly as a percentage. This represents now, because of the cost of healthcare in America, an amount that most individuals do not want to absorb. And thus, pretty much from the beginning of the creation of Medicare, the reliance not only on Medicare itself, but also on private insurance. And this is where things got complicated and frustratingly, overwhelmingly detailed. And if it was simply, I'm going to enroll in Medicare Part A and Part B, that's it, and I'm going to pay the balance out of my own pocket, and I'll do it when I'm 65, that was presumed to be relatively simple, but we're not in a simple situation any longer. So we're faced, because of the necessity of picking up deductibles and co-payments and co-insurance that Medicare imposes on the individuals, an embrace of private insurance. And there's a certain irony in that, because Medicare was created in the 1960s because individuals who would be eligible for Medicare based on age or disability found that it was difficult or impossible to access private insurance products at that point in time in the 1960s and earlier. Or what they were able to access was not comprehensive enough and often well too expensive for most individuals to afford. And so Medicare was created as a guaranteed basic insurance platform to provide those individuals that would be eligible based on turning 65 years old or based on being recognized as disabled, and a surety that at least basic health insurance would be within their range. But as the cost sharing became significantly more catastrophic for individuals, it became necessary, ironically, to turn back to private insurance as a way to subsidize for individuals that cost that they were not going to be fully expecting the government to take care of. There's also certain things that Medicare simply does not, likely will not cover. Things like routine eye care and routine dental care, the cost of obtaining and testing for hearing aids, and certainly long-term care, which is just an arbitrary definition of inpatient for a certain length of time in a skilled rehab or skilled nursing facility, defines at some point, and that point is 100 days, the recognition that the primary basis of care is no longer medical, but it's personal care. And thus, Medicare itself or the private insurance products around the Medicare system, or just private insurance in general, draws that line at 100 days. Prior to that, the institutionalization of the individual and the basic care of that institution are presumed to be medical and covered by the medical insurance. After 100 days, it's the reverse. The presumption is even if medical care is being given at that institution, the being in the institution itself, the being in the facility, the basic care, the feeding, the dressing, the toileting, the grooming, these are all things which are no longer essentially part of the whole medical package, but they are separate. Now they're personal care and they have their own cost, and there's a minimal or no reliance on the kind of health insurance that individuals would have in the Medicare system. So understanding that it's not just Medicare Part A and Part B and private insurance products that are going to help pay for those deductibles or co-pays or co-insurance that Medicare doesn't pick up. There's going to be some things that Medicare doesn't cover at all. And thus, if you want those kinds of services, you're going to also seek out other kinds of private insurance that are purpose-built for those things, like eye care, dental care, long-term care. There's three ways that you are going to go into the market looking for private insurance that's going to work with the Medicare system. Some individuals have the benefit of an employer that once the employee has ceased working, once they are retired or some way terminated from that employment, if they've worked for the employer long enough and met the criteria, the employer offers them as part of their exit package, their retirement package, their post-employment package, a benefit of health care. Doesn't mean they have to take it. It doesn't mean it's necessarily very good, but it's being offered. And there are a significant minority of employees that have this particular option. For example, employees of public school districts are likely going to have either directly from the school district or in tandem with a state benefit. That benefit will transition from when they stop working, if they're not yet ready for Medicare, to eventually when they do become eligible for Medicare, it will act as a supplement or an enhancement to their Medicare Part A and B, and it will insist that they enroll in Medicare Part A and Part B. Another example, individuals that work for the federal government. I'm talking about the old timers that worked long time ago, and still are around and still utilizing the federal health benefit. Those individuals are not even required to enroll in Medicare. Now that's a very unlikely exception, and most likely individuals that are offered an employer benefit package are going to be compelled to be enrolled at least in Medicare Part A and Part B when they become eligible for that. So it's going to work in tandem with Medicare A and B. And again, it's optional. The individual does not have to utilize this. They can turn it down and go shopping for something else. Another category of private insurance products, and this didn't used to be always private insurance. At one point, the utilization of Medicaid was another government benefit. But in Pennsylvania, in the past few years, the state government has turned over responsibility of administering the Medicaid system and the providing of benefits under the Medicaid system to private insurance companies. So if it was an individual because of your low income, but it doesn't have to be low income, it could be simply circumstances, such as I'm going into a long-term care facility, a nursing home, and I'm not going to be able to pay the entire cost of being in that facility. And for many individuals, they don't anticipate they're ever going to be looking at Medicaid. They're bringing in perhaps not significant amounts of money, but at least enough they always perceive themselves to be economically independent. $50,000, $60,000, $70,000, $80,000 a year. And yet, when one of the family members has to go into a long-term care facility, they've been in hospital, they've been in a skilled nursing facility, a rehab facility, long enough that it's now being recharacterized as a long-term nursing facility. And as the health insurance drops off, it becomes necessary for the family to come up with $5,000, $6,000, $7,000, $8,000 a month to pay for being in that facility. And if they cannot come up with that money, then most likely they're going to be relying on the state to step in, and that's Medicaid. So many individuals would have been offended with the premise at some point in their life that they were going to be relying on Medicaid, basically medical welfare, to cover costs for that individual or the family. Now find this is the only solution. And accessing Medicaid for the sake of being in a long-term care facility essentially means they're also accessing Medicaid to help with the costs that Medicare A and B do not fully pick up. But those two groups collectively are still a minority, albeit a large minority, of the people that are in the Medicare system. By far, the largest group of individuals that are in Medicare rely on their own acumen to go out into the market and find private insurance that will enhance or replace the basic Medicare Part A and Part B. And it's going to require, as they become eligible for Medicare or as they finally decide to go into the Medicare system, to make hard decisions about the type of private insurance products they're going to utilize, and try to master the context of integrating them with Medicare Part A and Part B, and simply understanding what it is they need, what it is they're going to utilize, and how to go about approaching the providing entities, the insurance companies, for picking up those products. You can take all of the Medicare private insurance products that exist and put them into one of three categories. The first category is the private insurance product is going to be a supplement to Medicare Part A and Part B. They're sometimes referred to as med subs. Most often, they're referred to as Medigaps. Sometimes employers provide a med sub or a Medigap as a retirement benefit, so that you're using Medicare Part A and Part B as your primary coverage, and one of these as a supplement. Another category of coverage in private insurance are advantage plans. Now, these are HMOs or PPOs. They're sometimes referred to as the Part C portion of Medicare. If you enroll in an HMO, a health maintenance organization product, or a PPO, a preferred provider organization product, you've effectively replaced relying on Medicare Part A and Part B. Unlike in the first situation with supplements, you're definitely relying on Medicare Part A and Part B as your primary coverage. In this instance, you no longer rely on Part A and Part B, you rely exclusively on the HMO or PPO product. As long as you have one of these products, you have eliminated the accessibility care under Part A and Part B. Doesn't mean you have to keep the HMO and PPO indefinitely. You can flip from one to another, from one company to another, or one of these products within the company to another. You can even give up your HMO and PPO altogether and rely exclusively on Part A and Part B again. There's going to be a problem if you try to pick up a Medigap or a MedSup type product later in your enrollment in Medicare. I'm going to talk about that in a bit. The third category are coverage that's been purpose-built, boutique products that are exclusively used for prescription medication coverage. And this is typically in addition to these two. So one might have a supplement that goes with Medicare A and B and a Part D plan, or one might have an Advantage plan that replaces Medicare A and B, and attached to that Advantage plan is going to be a Part D plan. So you're going to have 1 and 3 or 2 and 3 What you will not have is 1 and 2 together. It's pick a lane. And with that comes the limits and characteristics and qualities of each of these products. Additionally, not only are you going to be looking for what's going to enhance or replace Medicare Part A and Part B, and what's going to cover your prescription medications, but also remember some things Medicare and HMOs and PPOs will not necessarily cover at all, or if they do, not very well. And thus you may be also looking for additional products in the form of private insurance coverage for eye care, dental care, and perhaps even long-term care. These are all elements to anticipating how you're going to build your total care package and the strategy that you're going to implement to decide what's important, what's necessary, and how much you're going to pay for them, and what kind of coverage you're looking for. So this is a pretty good schematic of how you're going to anticipate building a coverage package. And if this makes it any easier, literally there are only 2 options. There's a number of spin-offs of these options, but you can categorize your choices in Medicare as either option 1 or option 2. So let's talk about that. Option 1, as I said, anticipate that you're using Medicare Part A and Part B as your primary coverage. You're going to supplement it with a private insurance Medigap. You're also going to pick up a standalone Part D plan to cover some of the cost of your prescription medication. And you may also consider coverage for non-Medicare covered services like dental, eye care, possibly even long-term care. What's the characteristics that this looks like? Well, first of all, if you're using Medicare A and Medicare B as your primary care, the nature of Medicare A and B as care coverage is now relying on a national system. That means you can go to any doctor, any hospital, any care provider, anywhere in America that agrees to take Medicare. Now, every hospital in America that you would imagine going to is going to accept Medicare, as well as Medicaid also, by the way. They do it because to be accredited, they do it based on their state's requirements to function in that particular geographic location under that jurisdiction. Most doctors are going to accept Medicare. In any given year, more than 95% of the physicians and practices in America accept Medicare. They may not like to. They may not like what they're reimbursed with, but they will accept Medicare. Most often they accept it because to have access to a healthcare system, particularly hospitals and other large service facilities, they need to also accept Medicare because those facilities also work within a Medicare umbrella. And the point of that is you have reach with Medicare A and B. Wherever you go, it is likely you will find the facilities that will take your Medicare A and B card, not just in your hometown and around where you live, but anywhere you may visit, anywhere you may travel to see your kids or grandkids, or just go on vacation. Medicare will go with you. Their portability is a significant characteristic. The other characteristic is the expectation of comprehensive coverage. Medicare Part A and Part B not only are national in scope and allow you to access fairly well the entire American healthcare system, but also in tandem with a significantly comprehensive Medigap. And essentially most Medigaps are significantly comprehensive or totally comprehensive, meaning the entire cost of your healthcare, both inpatient and outpatient, is fully paid for in a combination of Medicare A, B, and the supplement. And again, let me drive the point home. If you are diagnosed with cancer and have to go undergo a significant round of chemotherapy and radiation, the diagnostics, the access to the care facilities, With Medicare Part A and Part B, it is very likely you will be able to go to any of these facilities you wish, and in tandem with the Medigap, the entire cost of that care will be fully paid for. The operations you would undergo for heart disease, the hip replacements, the chronic and continuous and catastrophically expensive costs related to healthcare, both in and outpatient, will, with Medicare Part A and Part B and a Medigap, have an expectation of being fully paid for. Or if not fully paid for, essentially mostly paid for, so that the minimal residue of your cost is measured in, for the entire year, a couple $100. That is the potential reach of that option. The ability to go where you want, and the ability to have the expectation that those costs will be fully covered. And the third expectation is, not only can you go where you want and have those costs covered, but that promise of benefit coverage is locked in for the entirety of you holding on to that product. If for the rest of your life you maintain this product, continue paying the premiums, your expectation is that product will stay the same. Its benefits will be identical from year to year to year. It cannot be changed, and it cannot be taken away from you as long as you pay your premiums. Will the premiums go up? Very likely. Will they go up a lot? So far, the past 2 decades, they have not gone up more than about 3 to 5% per year on average with most reliable products. But there is no guarantee that will continue. But at the same time, the quality of the product is an incentive for anticipating paying the premiums. There's the also expectation that some things that are not going to be covered by Medicare A and B, and again, reiterating, basic dental, basic eye care, access to hearing aids, and long-term care, may be covered, at least to some degree, by other private insurance products that aren't Part A, Part B, or a supplement, or Part D drug coverage. And let me mention, at this point, Part D coverage is probably going to be the weakest link in this whole process. Generally, between a Medigap and Medicare itself, you have an expectation of entire or next to entire coverage. Part D is never going to be that comprehensive. It's not going to be nearly as expensive as a Medigap supplement, but it's also going to have significant cost sharing. No matter how hard you look, you're going to find it difficult to get a Part D plan that is going to be significantly comprehensive in its coverage. If you're lucky, you're going to be taking nothing but generic drugs. Or if you're truly lucky, you're not going to be taking any medications. But that's not the norm for most individuals in Medicare. In fact, the average number of prescription medications an individual at 65 or older is taking per day is at least 6 medications. And again, if you're lucky, those medications are all generic and the costs are going to be minimal. If any one of those is not generic, you're looking at a much more significant cost to access those drugs, and a very likely possibility of going into something called the coverage gap, the donut hole. And Part D plans do not ever comprehensively cover the cost of non-generic drugs, and Part D plans typically have a coverage gap, the donut hole. And that's another conversation for another time, but anticipate in a general way that the weak link of this process, whether you're doing option 1 or what I'm going to talk about next, option 2, is Part D coverage. And this is probably where you're going to focus some attention to make sure that you're maximizing that coverage to the best of your ability and the best of the product's availability. Now, option 2. Now, you are still required to be enrolled in Medicare Part A and Part B, but you are not going to utilize Medicare Part A and Part B. You are instead going to be enrolled in a Medicare Part C, a Medicare Advantage plan. The characteristic of all of these plans is managed care. These are HMOs and PPOs. They rely on a network, and regardless of what A PPO purports to give you nationwide accessibility or great reach. It is still going to be based on a network that if you stay in that network, it will pay a significant larger portion of the cost than if you go out of network. With an HMO, you go out of network, the entire cost is on you. With the PPO, the cost is a larger amount than if you stayed in their network. So yes, you may have a greater reach, but the cost may be preclusive for more significant and expensive services, and thus you'll still be looking at staying within a network. Part C plans can incorporate other things. So for example, a Part C plan could include with it Part D coverage. And that Part D coverage, although it's defined separately, is part of the total package. And the other thing a Part C plan, an HMO or PPO can include is non-Medicare covered services. It is very typical that an HMO or PPO product, not only including Part D coverage, will also include things like basic dental, basic eye care, and some things that might be defined as personal care services. Thing to know about that is you are very, very, very likely not going to have comprehensive basic eye care, basic dental care, or long-term care type services. These are going to be marginal levels of care. These are going to be basically add-ons for the enticement for you to come over to option 2. And there's nothing wrong with that, but understand the limits of that coverage. When individuals tell you in representing these products that with it you can get basic eye, basic dental, personal care services, Part D coverage. The Part D coverage is going to be likely about as good as what you would get in standalone, and often actually less comprehensive, but you're stuck with that Part D coverage. You cannot say, well, I like this, but I'd rather get a separate Part D. It's a package deal. And the other kinds of services are also going to be marginal in their quality, although you're not paying necessarily an additional cost, they're going to be less effective possibly than what you could get if you simply went out into the market and purchased a separate standalone dental plan or eye care plan or long-term care service plan. So they're there, but understand them being there is the incentive to woo you away from relying on option 1 with its characteristics to something that is less comprehensive. The characteristic of option 2 is less in a positive way and in a negative way. It's less accessibility to providers. You're going to stay within a network. You're going to stay within a geographic network and within a provider system network that's been defined as those providers that have contracts with this particular insurance company. It's going to be less, and they're going to cover less of the costs related to your medical services and your prescription drug services. A Medicare Part A and Part B and Medigap combination can expect to cover all or most all of the cost. A Part C is going to cover less by far than Part A and Part B and the Medigap in most cases of the high-end expensive services, like stays in hospital, cancer treatment, kidney dialysis. They may do an okay job or a perfectly wonderful job as far as accessing a primary care physician or the cost of seeing a specialist, but the costs beyond that are often far more expensive than what option 1 would entail for you. But at the same time, the positive value of the less is that you are paying less of a premium. It is very likely that you're going to find a HMO or PPO Medicare Part C product that's going to have a premium of 0. And you could probably categorize most of these products as well below $100. The ones that are 0 in premium, the ones that are 10 or 20 or 30, 60 or 80, by far less than $100 per month. Compare that to the likelihood that a supplement is going to cost somewhere between $100 and $160 when the individual initially enters. And yes, the premiums will go up, but anticipate you're looking at somewhere between $100 to $150 for the premium just for that. Keep in mind, you're adding this to the cost for Part B and the cost for your premium for Part D and the premium cost if you get standalone dental and eye care. So in comparing and looking at this total package, your expectation, assuming your Part B is going to be coming in at the base amount, $148 per month, for each individual enrolled in this option, expect that your cost per month is going to be approximately $300 to $350. And that $50 extra is likely the premiums for the standalone eye care and standalone dental. If you exclude that, if you're talking about a combination of Medicare A and B, a supplement, and a Part D, anticipate your monthly cost per person, including the cost of Part B, is about $300 a month. This is still going to require you to be enrolled in Medicare A and B, and that's still going to require you to pay the $148 at least per month per person. But by paying a zero premium or a $20 premium or a something less than $100, and they're folding in Part D coverage for that same premium price and folding in some of these other costs, they're presenting you with a package that could be significantly less than the premium amounts for these, significantly less by maybe a couple $100. And so you're going to be compelled to say, well, I'm not that sick. I don't have that many needs. I don't take any meds, or what I take are basic generics. Why would I want to spend $200 a month for this kind of a package when I could get that entire package for as little as zero, or at most 20 or 30 or 40 or something certainly less than $200? And the reason is because you're embracing the idea of the immediate low cost of premium and absorbing the risk that at some time down the road, you're willing to accept the escalated costs for a higher level of utilization. Now, there's nothing wrong with either of these choices, but understand what the limits and what the capabilities of each are. And there is no HMO or PPO that will give you the same comprehensive care that a combination of Medicare A and B and a Medigap will do, but it will come at a higher premium cost. And the additional stuff that they add on to entice you to see a value in going with option 2 tend to be add-ons that have some value, but not as significant as the core value of covering the entire cost of care and giving you access to the facilities you want to go to in a guaranteed way. There's something else to know about option 2. If you use an HMO or PPO, you're no longer utilizing Medicare A and B. The reliance on coverage is exclusively on a private insurance network. And that reliance is based on an annual expectation, meaning every year, the network, the levels of coverage, and the costs can and certainly will change. You cannot expect any more than a single year that the doctors you're utilizing will stay within that network. There's a good possibility they will, but there's no guarantee. There's no guarantee that the cost sharing that you're incurring this year will be the same next year, or the services covered this year will still be covered next year. These are transitional things. Every year, the providers of these HMOs and PPOs submit to the Medicare system the specs for this particular plan's upcoming year, and they invariably change. And Medicare approves the changes. They then offer it as a product in the October, November, early December enrollment season. You decide whether you want to keep it, get it, and it goes into effect the January 1st of the upcoming year. And it's good for the year from January 1st to December 31st. Every year, there's a little dance going from what are you going to cover? How are you going to cover it? Do I want it? Do I want to look for something else? So there is an expectation of change, an expectation of uncertainty. Whereas this is a lock-in. When I have this and this and this anticipates I'm going to be utilizing this for an extended period. Most likely, it's going to be for the rest of my life. If I get a perfect product, and if I can afford the cost of this perfect product, statistics tell us that I'm likely going to stay with that for the rest of my life. This is far more transitional. And it's also based on the idea that I understand that in the immediacy, I'm not looking for significant care, just good enough care. And the perks that come with this, the free dental, the free eye care to the extent it's covered, and the health club memberships, and the personal care, and the concierge services, and all that stuff is great. And because I'm not using a lot of services, those things carry a certain value, more than a comprehensive coverage of the cost of the care that I would be receiving. Something else too, the way that the insurance companies can offer an HMO or PPO at a zero premium, and believe me, there are a number of products out there in any particular county, any particular region that are going to be offered at a zero premium cost, even with all the bells and whistles attached to it. The insurance companies are able to offer them at a zero premium because they're being heavily subsidized by the federal government. If they can talk you into enrolling in an HMO or PPO, and the talking into is, I'm giving it to you at a very low premium and I'm adding all of the additional bells and whistles onto it. If I can talk you into that, then from Medicare itself, I get a monthly subsidy for my insurance company of about $1,200 to $1,500 per person that I enroll in my product. I will make more money in terms of premium off of getting you into a zero premium HMO or PPO than I would by selling you a Medigap for $100 or $120. I will make a greater profit margin by pushing this product than that product, to the point it's very likely you're going to be confronted with these options more aggressively than these options when it comes time to go looking for products. This is where insurance companies will make the largest share of their money if they are in that regional market for offering HMOs and PPO products. And thus the incentivization of a little bit of dental care, a little bit of eye care, a little bit of personal care, a little bit of concierge service is the cost of doing business to entice you into something which they will make a much larger amount of money, even with the expenditures for those kinds of services, and even with no revenue coming in the form of the traditional premium. It's the backdoor reimbursement from the government that is the enticement to push these products, such as currently and for long stretches of time, one particular insurance company that you'll recognize, UPMC, doesn't even bother to sell these products. To them, honestly, it just gets in the way of pushing their HMOs and PPOs. They will make far more money, and because of their dominant network in at least the southwestern Pennsylvania region, this is where they're going to focus their marketing, and this is where they're going to focus their insurance product development. So much so that it is very likely that you're going to find that with UPMC, there is a strong push to embrace that kind of product. Certainly over Medigaps, but also over even products that are being offered by an employer that represent a MedSup or supplement to Medicare A and B. And that doesn't make them bad. It just means they have their own value. They have their own strengths, and you simply have to anticipate what that's going to look like. Now, this is just a quick slide. You can take a look at it. It's available for you to give you an idea of the levels of comprehensive coverage that the Medigaps offer. Medigaps are also simpler in terms of looking at to anticipate what their coverage is going to be. All Medigaps that are offered must adhere to the category in which their type is marketed as. So a company selling a Medicare Medigap Part A must adhere to that level. They cannot vary from that. And if they sell an F level Medigap, they will adhere to that. So you can do a quick determination when you're looking at which particular Medigap category. And if you go to Highmark and say, what's your F level Medigap cover? And United and Cigna and Aetna and Stinky McStinkface's insurance company, their F level is going to be identical. Their G level is going to be identical, and so on. The difference will be simply the premium. That one person's F level Medigap may be $140, one may be $143. And this is where the shopping for Medigaps vary much more than the shoppings for HMO or PPO, which are variant by all sorts of possible characteristics and coverage and cost and bells and whistles added on, which makes the shopping for an HMO and PPO a bit different. This is also elemental to what you're looking for prescription medication. As I said, any of the Part D plans, whether they're a standalone Part D or a product that is attached to an HMO or PPO, is going to have an initial coverage, which is about 75-25% split between the plan and the beneficiary. Will then, once you have spent about $4,000 of coverage in obtaining your medications, will put you into a coverage gap and thus eliminate the reliance on the drug plan to cover the costs. You're in the coverage gap until you have spent your way out by a bit more than $6,500. So what puts you into the donut hole is the purchase of drugs that add up to about $4,100. What gets you out of the donut hole is an expenditure out of your own pocket that adds up to a bit more than $6,500. But know this, while you are in the donut hole, the federal government will step in, not based on income, but simply based on being in the donut hole. Any individual who is in the donut hole based on being enrolled in a Part D plan has the expectation that 75% of the cost of the drugs, both generic and non-generic, will be covered by a combination of the government, the manufacturer, and eventually assisting you in buying your way out of the donut hole. Now, the purchases that the government takes over, that's 75% that the plan was responsible for. That still counts towards meeting that $6,550, which helps get you out of the hole a bit faster. Once you're out of the donut hole, the final stage for the year is catastrophic coverage, whereby you have an expectation that the insurance company is back online paying about 95%, and the beneficiary paying only about 5%. Now, the importance of that is when you're looking at a Part D plan and have the expectation that you're going to go into the donut hole and the government is going to step in to support and eventually buy you out of the donut hole at some point, and you are back online with catastrophic coverage. The expectation is that whatever the plan promises it's going to cover is only good at this point. Because once you're in the donut hole, the plan is done. The federal government steps in and starts splitting the cost of your drugs, 75-25. And once you're out of the donut hole, the plan comes back on with a mandated 95-5 split. So any promise of how better they can pick up the costs than 75% is only as good until you hit the initial coverage limit. After that, they're done. the government steps in at a 75-25 split. And once you reach that amount, the plan comes back online, but they have to come back at a catastrophic level. So individuals often go shopping for saying, ooh, this plan will cover 80% or 85%, only until you reach that number, at which point they're done, government's in. When you reach that, they come back online, but whatever promise they've made here, it's 95.5. And the irony I point out is often a cheaper premium plan works better than laying out hundreds of dollars a month in premium, thinking you're going to get better coverage. Only as far as this layer, once you hit this layer, and often people get $100 premium Part D plans because they're taking incredibly expensive drugs. They're going to be in the donut hole and out of the donut hole within the first month or two. Any promise made at this level is overridden by being in the donut hole, where the government is absolutely doing a hard 75-25 split, then ultimately an absolute 95-5 split. This has little consequence when you're going into the donut hole in the first month or two. And I find that many individuals overpay for premiums for their Part D coverage unnecessarily, because the coverage expectation fails once you get past this level. And finally, making the right choice. Making the right choice starts with you prioritizing the things that you want the plan to do. And there's really essentially characterizing the plan's qualities based on the characteristic of coverage, the ability for the plan to guarantee specific services and products. And regardless of what they promise, generally, it's about what you need particularly, and not just for now, but what you expect you're going to need down the road. The medical care, the equipment, the medications, and it's also accessing. Does the plan let you access the providers you want to go to? And what's your belief that they'll allow you to continue to access those? A plan that says we represent the entire national healthcare system has a good likelihood that for the rest of your life, you'll be able to go where you want and get what you want, rather than a plan that is based on limitations. And how important is access to you? Some people will say, I don't care what doctors I go to, they're all the same to me. And some people will say, look, the coverage is not that big of a deal right now because I don't have that many services, and I'm willing to accept the risk. There's a couple other things, though. The process of how you access those services, how that plan guarantees you entry into it. So it's not simply we have certain doctors you have to go to, certain facilities you have to use, but also what hoops do you have to jump through to access those at those providers that you're seeking, and how will these limits of who you can go to manifest in ways that I can't get a second opinion, I can't get an additional diagnostic, I can't stay in the facility longer than a few days because I'm limited to those facilities, I'm limited to this network, and I'm limited to their dictation of how I'm going to utilize these. And finally, the cost. So it's the quality of how well is it going to cover, how well am I going to access, and what's the ease of process in getting those services, but also how much are they going to cost? And there's the initial cost, that is what it appears to be in terms of premiums, but the total cost. And it's the premiums I have to pay initially, but also then later the deductibles and co-payments. So some people see the premium of zero and say, well, look how cheap that is. It's low in its initial cost, but if you guess wrong in terms of your health for that year, you could be facing, in tandem with deductibles and co-payments, a cost that far exceeds what you would have paid in an initial premium. So how do I guess that? How do I anticipate one versus the other? And this is the problem. You're faced with a hard decision when you initially enter Medicare. And that hard decision, simply put, is you have 6 months to select this option of Medicare A and B and a Medigap. During the first months in which you enroll in Medicare, specifically the Part B portion of Medicare, you are entitled, regardless of your health, your age, your circumstances, to obtain any level of Medigap that is being offered. Once those 6 months have passed, if you are not enrolled in a Medigap, if you're in option 2 or simply chose to get Part A and Part B and not picked up a Medigap, you can no longer be guaranteed access to a Medigap for the rest of your life. You can still attempt to purchase a Medigap after your first 6 months of enrollment in Medicare. You'll be likely subject to underwriting. And if your health conditions are significant or simply within the past 2 years, at the point in which you're trying to purchase a Medigap, you may find that you're being turned down by insurance providers. Now, there's always exceptions, and there are things literally called triggering events that are exceptions. But there's no guarantee, and in fact, it's a less likelihood that you're going to have any of those triggering events occur, and a greater likelihood that the only way after the initial 6 months, you'll be able to get a Medigap. You can certainly go from this to this. You can give up your Medigap and go into an HMO or a PPO at some point in your life for whatever reason you choose. They must accept you each year during their enrollment season. However, if you have chosen this option or chosen not to pick up a Medigap of some kind, the ability to go from this to here or simply obtain a Medigap with your Part A and Part B or change your Medigap to a different Medigap is going to be based on successfully going through underwriting, which likely, if you're compelled to change from this to this or a Medigap to another Medigap, it's most likely because the coverage you chose initially is not as good as you would hope it would be or as effective as it would be. And most likely now you have a health condition which will deny you access to the Medigap you're seeking. So this isn't simply looking at the characteristics that represent the best coverage for you. It's also thinking three-dimensionally. It's not just what's now, but what I anticipate my future is going to be and how I anticipate covering that. And again, looking at these are not just in terms of the immediacy, but over the long haul, knowing that the possibility of getting this product later is going to be significantly limited once you're in the Medicare system for a short length of time. So one other thing, the way you're going to access your healthcare, the way you're going to access your product is going to be seen two different capacities. The accessing of your healthcare is going to be navigating through doctors and hospitals and healthcare systems. The way you're going to access the product that represents the coverage that lets you access the care is invariably through an insurance broker, a health insurance broker. The concept of broker is just a term. It's an individual who is licensed in this particular jurisdiction, Pennsylvania, to be able to sell products, healthcare coverage products. They likely could sell HMOs and PPOs. They likely can sell Medigaps. Many of them are what are called captured brokers. They are representing only one particular company. Many of them are independent and they can represent many different companies. But the issue of a broker is that individual is going to be representing the insurances that they're licensed to represent and contracted with the insurance company to represent, and they're paid a commission to sell that product. They will tell you, you owe no fee to me. I'm going to be compensated in the commission that I make by selling that product. And thus, when you approach the broker, there is nothing inherently wrong, and this is the way you're going to do it regardless. It's a question Are you telling the broker what you want? And the broker is simply acting as the facilitator to get you enrolled in the product. Or is the insurance broker telling you what you want? And the broker is your advisor. And the question becomes, is the advice I'm getting worth listening to? Is the information compelling based on it makes sense to me for my needs, or is it simply the individual is compelling me to pick a product because it's serving that broker's needs to push that particular product? And individuals that represent a single company are certainly going to be more compelled to tell you about that company's good qualities and that product from that company's good qualities rather than all the other products that exist. And even individuals that represent certain lines of products are going to be compelled to talk about those particular lines. And don't forget, the commission for HMOs and PPOs may be quite different from commissions for Medigaps. And thus there's always that incentivization to say, a Medigap may not be as profitable to sell as an HMO or a PPO. And these are all things that you're going to be contemplating. Now, you can go into a process of shopping for a product prepared to focus on the product concept that you want and even the products you want, and thus instruct the insurance broker what you want ahead of time. And their job is to simply get you enrolled in that particular product from that particular company. And the process usually takes about 15 minutes. It's literally a phone call saying, I know what I want. I've done my homework. I need you to do the application with me. Can you do that? The application should take 15 minutes and you should be done over the phone. On the other hand, if you come to a broker saying, I don't know, I'm new to Medicare and I can't make my mind up, can you help me? Then that individual is going to be your advisor. That individual is going to tell you what you want based on their expertise, based on their direction. And now you have to wonder, is what they're telling me in my interest or their interest? Do they have a bias towards a particular product that is truly giving me a comprehensive look? And are they willing to facilitate what I truly want or need? Or are they directing me in a direction that is beneficial more to them than to me? And the way you anticipate that is to put as much time into understanding the products that you're looking for, the process of getting them, and the value of what those products are going to be in your utilization. There is two kinds of people. The people that just want to get it done and are looking for the fastest, easiest way to facilitate because it's, at least at this point, not that important, versus the people that understand the importance of this insurance. It is a significant part of the decision they're going to make, and it's something they know they're going to have to live with down the road. And as a result, they're going to put in far more time and expect less of the broker than of their effort to understand how this works. And there's nothing wrong with asking the broker the questions, but understand before you ask the questions, do you have a pretty good idea what the answers are going to be? And expect that whatever you're being told is something that you're going to, before you make a commitment to a particular product, you're going to investigate at least one more time over. Getting a second opinion, even getting a third opinion on products is not a bad thing, which means you're going to put time. There's going to be a significant ramping up to picking up your products, not just enrolling in Medicare, and there's going to be an effort put into it. Now, there's nothing wrong with that. And there's nothing wrong with the person that says, look, I just don't want to do it. And at that point, I'm sure you'll find a broker that's more than happy to tell you what you want, what you need, and enroll you in that product. Questions?
All right, thank you very much, Bill. We had one private comment that I think I'd like to sort of turn into a question.
Go ahead.
The individual mentioned that while they have original Medicare and a supplemental insurance, The Medicare Advantage plans option 2 often have large out-of-pocket deductibles you have to pay for surgery and so forth. Are those deductibles uniformly large, or are there different plans that have, different types of deductibles available?
Well, and this is, again, part of the bugaboo about, let me back it up to the, this is part of the bugaboo about shopping for option 2. Literally, there are perhaps a couple hundred different HMOs and PPOs available in your particular neck of the woods. And some of them are going to have deductibles. Some of them are going to have no deductibles. Some of the ones that have deductibles are going to be large, and some of them are going to be small. And you're going to just have to anticipate what you're looking for. And you're going to be potentially looking at all of them. I recommend, as I said, this one's relatively simple. I know A and B, I know what it's going to do, and I'm looking simply at categorizing my Medigaps based on which category of coverage and what's the premium, and every company is going to be selling the same. There is no similar product that is absolutely identical from one company to another or one product to another. So you're going to find every one of those couple hundred products are going to be slightly different. Some of them will have deductibles, some of them won't. Some of them will have co-payments for certain services, some of them won't. The best thing I can tell you as a universal is the more complex and expensive the service is, the more likely it's going to carry with it a deductible and or a large copayment. It is very likely, for example, that cancer treatment may not have an initial deductible, but it certainly is going to impose on you a 20% cost share. Kidney dialysis, the same thing. Inpatient stays could be measured in the hundreds of dollars per each day you're there, or a flat amount, but still going to be measured in the multiple hundreds of dollars. And yes, many of these plans will carry with it a deductible of several $100s, maybe even a couple $1,000s before the plan kicks in, thus making the shopping even more difficult. Now, a way that I find in terms of narrowing down the process is to first start by asking the question, and hopefully the answer is yes, I definitely want certain doctors and hospitals. Well, at least in option 2, that eliminates the plans that don't cover certain doctors and hospitals that you want to go to. And then it's a question of saying, this is the most I want to pay in premium. And then once you get to that point, it's simply capping that and looking at what the impact of this is. If you start with, I'll just look at them all and see if I can find the best one, you're going to get into gridlock real fast. You're going to be bouncing from plan to plan to plan. And by the time you get through the first 10 or 20, you've forgotten what that first one is. Wasn't there somebody that's going to reduce all this? Not necessarily. And again, you're relying on a guy who is being commissioned to sell the biggest and bestest thing that that company is offering as their incentivization. I have often come across clients who are sitting on a PPO or an HMO that they are paying literally $300 or $400 a month in premium, and they've been using this for the past 2 or 3 years. And the reason they got it is because they simply assumed that a product that costs $300 or $400 must be the best. And the truth is, it's not the best. It's just the most expensive. The coverage that that offers is not that much better than the one that's for $0 or $20 or $30 or $40. They just don't know how to measure the quality capacity, and they're reliant on somebody else to tell them what is the best. And honestly, when it starts to get to the ability to sell a product that's going for $300 or $400 versus a product that's selling for $0 or something less, and a commission is going to be based on that, there's always that concern. Is this really the best? Why is it the best? And the easiest question you can ask is, prove to me why this is better. Prove to me why this is going to cover my needs. And honestly, what you often find is they haven't even delved into your needs or concerns. It's simply a transactional process. This is the best. Why? Because it's the most expensive. This is the one I would recommend. That's when you need to be scared of the process. Next question.
I would imagine that this next question could possibly lead into another full hour of explanation. However, regarding the two different options, is there a better option than basic Medicare Part A and B for uh, long-term care, such as like nursing home care?
Know that in option one, Part A and Part B, because Part A and Part B say we will not cover long-term care services at all. Once you cross that threshold into long-term care, Part A and Part B will completely and automatically drop off. And a Medigap is a supplement to A and B. Therefore, if Medicare A and B doesn't cover something at all, the supplement won't either. So you're going to be compelled to say, well, what's the possibility? What's the concern? What's the risk that I have of needing long-term care services at some point? And honestly, it is a significant risk. And what are the products that I can pick up that will offset that? Alternatively, option two, and this is the be careful part, we'll say, oh no, we include as part of our total package non-Medicare services. And oh my, you should see what they are. We're going to give you care in your home. We're going to give you care that represents personal care. Be careful. There are limits on what those care are, and there's certainly cost sharing. Forget the cost sharing. Simply, there are limits. How many hours, what types of services, who's providing them. And you're at the mercy of that provider. You're at the mercy of that person coming to your house. This is who we're giving you. This is the service you're getting. Well, I don't like that person. I don't particularly like the service that person's giving me. Tough, that's what you get. Well, I want to get something else. Well, not in our plan. And these are the list of providers that we utilize. If you don't like it, go get someone else and pay them yourself. So this is what it represents, an add-on, a perk. It often represents a minimal level of coverage, a minimum level of service, which is the incentive for you to take this product so that they would get reimbursed by the government. But it does not necessarily represent higher quality of service, which compels you now to go completely out of this plan. And just like in this situation, look for something completely separate from the plan that represents your needs in a more effective and comprehensive way. Again, a separate standalone long-term care policy, or figuring out well ahead of the need how you are going to position your wealth to guarantee these care needs, if they arise, when they arise, are going to be effectively met. That's a whole strategy unto itself. My recommendation is do not rely on the promise of an HMO or PPO, which, even if it looks good and probably may be good, might not be there when you need it. Remember, every year, any promises made are only good for that year. What they giveth, they can taketh away in the following year or years. And if you're buying something with the expectation that this is going to be around when you need it, don't count on it. Next question.
Okay. I normally try to take questions in order, but this one came in while you were, so I just want to use it as a sort of a follow-up. So are there limits? You've talked about limits to where you can go and what doctors you can use, under certain options under option 2 versus option 1. Does that also apply to things like long-term care facilities?
Yes. And again, anything that's going to be within option 2 is going to be based on providers that have contracted with the insurance company. So it's not just the doctors and hospitals, it's the home care providers, it's the long-term care facilities, it's the whatever is going to be offered as part of their coverage. Dentists, eye care providers, health club memberships, all of these things are based on companies that have agreed to contract with the insurance company, with the Highmark, with the UPMC, with the products. And those are the entities that are going to be under their network. And if you expect this insurance company, the Highmark, the UPMC, the Aetna, the United, to pay for this in this Part C format, then you better be going to these providers, including the medical services, Medicare services that contracted with. And you may not like them. Tough. These are the ones you're going to work with, whether you like it or not.
All right. Next question. If you have signed up for Medicare A and B and you still have a full-time job with health benefits, will there be a problem in getting a Medigap after your job and benefits end?
That could very well represent a triggering event. So here, it's worth mentioning real quick. A triggering event is something that you had no or only minimal control over the process. You lost your current HMO or PPO because the company went out of business, or because the company said we're just going to discontinue next year. Well, you had no control over that. Or you stop working for your employer, and you kind of had control over that, but your employer says, when you stop, I'm taking your health benefit from you. At that point, that's a triggering event. And you move to another location, and that HMO or PPO doesn't travel with you. It's like, sorry, if you go there, we're not there, so we're going to discontinue the service. That's a triggering event. But look at the kinds of things we're talking about. These are things which are usually a life-changing event, usually significant. Losing the product isn't that life-changing, but it's also not very likely either. The likelihood of you moving to another location completely out of the realm of your HMO or PPO coverage, the possibility of the company going out of business or changing or dropping the product, the possibility, and this is usually most likely a once in a lifetime occurrence, that you stop working for an employer and that employer takes away your employer health benefit. These are things which are singular. And yeah, they're triggering events. And yeah, they give you a added opportunity to pick up a Medigap. And I'll give you one other. Literally, I had a situation where a daughter calls me and says, oh my God, my mom screwed up. It's like I couldn't be with my mom in her facility. She's not in a nursing home, but she's in a senior living campus. And I just didn't have a chance during the pandemic to be with her as much. And I found out she didn't pay her premiums. And I won't tell you the company, but you'll know it. And they said, no, I'm sorry, you didn't make your premium payments, or you were late with them for 3 months in a row, we're dropping you. And the doctor said, I thought Medicare said they were going to, yeah, Medicare allows them, but they don't demand them. So this company is playing it absolutely tight and saying, you screw up, we're gone. And it just, you'll see in a second why it's just amazing me that they're turning the business away. So I said, look, how old's mom? She's 93. Oh, God, okay. And she's not going to have any exception to being able to get back into a plan normally. She's potentially lost her plan. And we're talking what, March? The first she's going to have a normal crack at getting back into an HMO or PPO is January 1st of the next year. She'll have to wait till enrollment season to pick up another one. So I said, look, this is an absolute Hail Mary pass, but there's a possibility, and I mean, this is so extreme and this is so frighteningly bad for her, that it's worth at least looking at. What's mom's health? Well, she's actually in pretty good shape. Has she had 20 or 30 different conditions that I went through? It's like none of them. Really? It's like, what meds is she taking? And she's got one med, but it's, a maintenance med. The rest are all generic. It's like, I'm going to throw a Hail Mary into the end zone and see if this works. We're going to see if we can get her enrolled into a Medigap. Now, a 93-year-old person, under normal circumstances, I would say has a snowball's chance of getting a Medigap. And we're just in the right place at the right time, and God was good and said, yeah, we can do a Medigap, the company I went to. It wasn't cheap. The Medigap is going to cost almost $300 a month, just the Medigap. But, and by losing her HMO or PPO, was actually a PPO. She still had Medicare A and B, but that's the only platform she had. And the possibility of something going terribly, terribly wrong and incurring 20% with an unlimited cost was worth looking to see. So for $300 extra, we had the chance of enrolling her in a Medigap. Now, something I already knew, but I'll reveal this to you. The person who had got her into the PPO had got her into one that cost $380 a month. She was actually getting an F-level Medigap, better coverage than the PPO, for about $80 a month cheaper, even at 93 years old. Happy ending to the story. A reliable company, a reputable company said, okay, for that kind of money, sure, we'll do it. And because she's really passing muster. The underwriting process took approximately a week, maybe a bit more, came back and said, we'll take her. Part of it is they were also hungry for business. They want to crack into this market and challenge the entities like UPMC and Highmark that have locked down this region in their HMOs and PPOs. So they were willing to be a little bit more flexible. Now, there's no guarantee that next year or the year after they would be as flexible. There's no guarantee that the premiums would even be that. But right now, this was the perfect positive storm. Everything hit the right way. And the guy that sold this product to her, when originally the daughter confronted him saying, well, what can we do? His response, well, there's nothing you can do. It's like, keep in mind, the role of the broker is to get you into the product, to make the sale. And no matter what they promise is going to be after the maintaining of the product, the function, that's why there is a customer service unit for that insurance company. And very likely what's going to happen after the sale is done is thank you very much. It's wonderful and good luck. Until it's next year, we can see if we can sell you something else. Part of what you're looking for in terms of the process is a person who is not only going to help facilitate getting you in, but is going to help navigate you through the process of utilization. And for that, you're going to need something different than a broker. And it's going to be not based on a commission-based relationship. Next question.
All right. The next question, if you currently have high-cost medical expenses for equipment and supplies, and you're anticipating to be using this kind of equipment whenever you're enrolled in Medicare, when you enroll in a Medicare plan, would it be best to enroll in a Medigap plan in option 1 or a provider in option 2?
Well, there's two characteristics you have to keep in mind in this case. A good Medigap will pay the entire balance, what Medicare A and B doesn't. And we're really talking Medicare Part B here. This is what's called durable medical equipment, wheelchairs, hospital beds, breathing equipment, that sort of stuff. It's called durable medical equipment. That's under Part B. And typically there's going to be a 20% cost share under Part B with certainly these kinds of things. A Medigap, a good Medigap, like an F Medigap, will pay the entire balance of that 20%. So you're going to have full coverage for this kind of equipment. But Medicare, over the past decade or so, has created a limiting aspect of this is the one time in the one circumstance, at least now, that Medicare says, look, you can't just go to any provider that is willing to accept Medicare. We, Medicare, are going to dictate which providers, durable medical equipment providers, that we're going to allow to represent Medicare in this particular region. The rationale for that goes back a few decades, that the cost of durable medical equipment was one of the biggest costs that Medicare as an entity shared. And because of the cost of wheelchairs and equipment like that, this was a big ticket item. And they wanted to cap the cost and the shares of that. And they wanted to compel providers to compete to bring in the lowest bid. Now that has good and bad qualities. And as a result, what they're faced with now, individuals that are using option one have to figure out which durable medical equipment companies are contracted for that particular year or that particular cycle with Medicare. It's like, well, so it's better to get option two? Not necessarily, because all Medicare did in this case was mimic what a HMO or PPO plan does. They do the same thing. They compel individuals to bid contracts for how much this is going to cost, what this is going to cost the insurance company, and they give out these contracts very sparsely to durable medical equipment providers. So one thing I would recommend, this will cover a bigger part. This will always have cost sharing. This will cover a bigger part, but there will be limiting on who you can go to. So first, find out in your region, if you anticipate durable medical equipment, who are the equipment providers. And keep in mind, just because they're the equipment providers this year doesn't mean they're going to be the equipment providers forevermore. This is an ongoing bidding process. And if they're the ones you normally would go to and they are a reliable company and you like working with them, then there's nothing wrong with utilizing them. And keeping in mind, they might not be around with Medicare forever. Just like the providers under this HMO might not be around with them forever. This is the bad and worst of the situation. This is the one time where the expectation of comprehensive fails intentionally by a government policy. And if I could change one of the things with Medicare, probably Part D drug coverage would be the first thing. Durable medical equipment would be the next thing. Next question.
Okay, and it looks like actually this is going to be our final question here. One question, is the person correct that the prescription plan is an additional plan to Medigap in option one?
Yes. This is really a four-corner thing. Part A, Part B, well, think of 5 corners. Part A, Part B, each corner. A supplement, a separate corner, a separate product. Part D is a standalone product, a separate product. Doesn't have to be from the same insurance company, could be from the same, but often is not. And finally, doesn't mean you have to, but the other kinds of products that represent non-Medicare covered services that are completely out of the Medicare umbrella. By the way, let me throw this in real quick. If I didn't get to your question, if you think of a question that didn't come up at this point, here's what you can do. At the very end, or at the very beginning, is my email address and my phone number. As Dave indicated at the very beginning, we are a 501c3 nonprofit organization. We are not brokers. Intentionally, the people that represent our organization they're not allowed to have brokerage license. The people that represent our organization are physicians and pharmacists and lawyers and social workers that are compelled to counsel and advocate, not sell. Now, I'm not denigrating brokers, but I'm simply saying we have a different approach to this. And we will be more than happy to answer your questions and help you navigate through the process. So by all means, reach out to us if you can think of something you'd like to talk about.
All right. Well, Bill, thank you so much for the wonderful presentation. Again, this was well received. I've gotten a lot of private messages indicating how much they were, the participants were enjoying the presentation and the information you were sharing. For those of you who are interested in possibly revisiting the presentation, we are going to put the recording of the presentation up on our website. It should be available to you starting at some point tomorrow on ameriserve.com/presents. And of course, if you know somebody who you feel would benefit from it, the public or the presentation will be available to the public free of charge. You don't have to have attended or anything like that in order to view it. So with that, Bill, I want to thank you again for being here, and hopefully we can welcome you back soon for another session.
Thank you very much, guys. Be safe. Stay sane. See you later.